A good night's sleep does not come easily. Sleep promotion is a collaborative effort, particularly in the acute care hospital setting. Patients over 65 years of age account for more than 48% of all days hospital care in the United States. The importance of sleep does not diminish just because a person is admitted to the hospital. In fact, the need for sleep is greater during periods of illness, and adequate sleep is critical to optimizing recovery. However, approximately 50% of the general medical patients complain of sleep disruption. This percentage can be even higher among the patients in the intensive care units. Often unrecognized and unmanaged during hospitalization, poor sleep affects recovery from illness and can increase the development of chronic sleep disruption. Sleep has been linked to outcomes which are critical to patient safety and healing, including falls and delirium. Delirium is an acute confusion state presenting as severe confusion and disorientation. It has been shown that delirium predicts a threefold higher mortality within a year, a longer hospital stay, higher costs of care, and long-term cognitive impairment. Each additional day of delirium independently increases the risk of death by 10%. Older adults are especially vulnerable to the development and persistence of delirium. Patient-centered care is fundamental to healthcare quality. Unfortunately, it is not adequately considered in the current practice of how we manage patient sleep. Clinicians joke to patients that you don't come to the hospital for good night's sleep. In contrast, here's what we hear from the patient's family member. In a recent 4-day hospital stay, one of my relatives literally had no more than a couple of hours of sleep at any one given time. Even though he probably shouldn't have been released when he was, he demanded to be released so he could finally get some uninterrupted sleep and begin to heal. He actually improved dramatically shortly after leaving the hospital. The lack of patient-centered care for sleep has also been evidenced by the common inpatient pharmacological sleep aid use, even in older adults. Despite recent warnings regarding side effects, including inpatient delirium and falls, especially in older adults, in a recent study we found that over 1/4 of the patients received a medication for sleep complaints during hospitalization. Promoting sleep in the hospital has been difficult. Oftentimes, clinicians' intentions for managing patient sleep are impeded by poor communication and a lack of guidance in how to assess and manage patient sleep. As one nurse articulated her frustration in trying to improve patient sleep, we have so many systems that are built on what's convenient for the physicians and the nurses and the housekeeping and everybody else, and the patient was the last one considered. One question we frequently hear from both patients and clinicians is how to evaluate sleep. Sleep can be assessed in multiple ways, either subjectively or objectively. Here, I would recommend 2 questionnaires: the PROMIS sleep disturbance and PROMIS sleep-related impairment. PROMIS stands for Patient-Reported Outcomes Information System. The system is funded by the National Institutes of Health. It uses highly reliable, precise instruments of patient-reported health status for physical, mental, and social well-being. The PROMIS sleep disturbance assesses self-reported perceptions of sleep quality, sleep depth, and restoration associated with sleep. The PROMIS sleep-related impairment focuses on self-reported perceptions of alertness, sleepiness, and tiredness during usual waking hours, and the perceived functional impairments during the day associated with sleep problems. Both instruments are appropriate for gauging the severity of sleep problems across a range of conditions. They can be efficiently administered via computer interface with direct data entry and scoring, or by traditional paper-pencil method. Another major challenge of sleep promotion is that there is no one-size-fits-all intervention, as patients' sleep may be disturbed by different factors. We have identified 4 categories of sleep-disturbing factors commonly reported in the hospital, including hospital environment, patient care activities during the night, anxiety and other emotional distress, and pain, dyspnea, and other discomfort that prevent sleep. Therefore, interventions to improve sleep should extend beyond simply prescribing pharmacological sleep aid, but work to address multiple medical, behavioral, and environmental factors that impact sleep. My study team has recently received funding from the Agency for Healthcare Research and Quality. We will use health information technology to address the key issues of inpatient sleep promotion, including routine assessment, open dialogue with the patient, collaborative care planning, and tailored interventions. The health informatics intervention we're developing is called Sleep Kit. Using the Sleep Kit, patients start the assessment sleep and sleep disturbing factors the previous night. The Sleep Kit software identifies a core set of evidence-based interventions directly linked to the patient's specific sleep-disturbing factors. The assessment data and the associated tailored interventions are then processed by the Sleep Kit software to generate a single care plan for sleep and personalized educational content for all care providers, patients, and family members. We hope this will lay the groundwork for making inpatient sleep promotion effective and feasible, which will ultimately change current clinical practice related to patient sleep, hence leading to meaningful improvement in patient health, cost, and quality of care.